It's time to give the people what they want. Grab your piece of paper and let's go. Hello and welcome to the Bazooka Season 3 Revamped Episode 6. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at 10 OSCE stations in one clinical course. In today's episode, we're going to be looking at pediatrics. If you haven't yet subscribed to the channel, please subscribe to the channel. Hit the bell notification icon to be receiving such notifications of such videos every time I post. Drop a comment, drop a like. Grab your piece of paper and let's go. In the gist of these videos, you may pause the video at any point to scream the answer at your screen, to yell it at a piece of paper, or even a friend if you're watching them with a friend, I guess, or to write down your answer. And here we go. Station 1. A 19-year-old mother brings her child and presents to hospital with a history of recurrent upper respiratory problems. A picture is shown of the child's legs. What is shown in the picture? What is the diagnosis? How do you grade the lesion? List the principles of management. So this is the picture here on the upper right corner, and this is the typical history that you are actually given. So you may pause the video right now. And here comes the answer. So this is obviously what is referred to as a flaky paint dermatosis, where the skin is peeling off. We can see that there's peeling off of the skin on the left leg. So this is obviously going to be in the background of severe acute malnutrition. Most likely this child has severe acute malnutrition. Why do I say so? The age of the mother is quite young. A young mother may not necessarily know how to take care of the child. But I'm not saying all 19-year-old mothers do not know how to take care of the children. There also is a recurrent history of upper respiratory problems, upper respiratory tract infections. So putting all that together, this child most likely has a severe acute malnutrition. And remember, dermatosis is graded as mild, moderate, and severe. There's 1+, 2+, and 3+. So 1+ if there's a discoloration or a few rough patches of skin. 2+ if there are multiple patches on the arms and or the legs. 3+, which is severe, which is flaking of the skin, raw skin, fissures, which is opening of the skin. So this child is most likely at 3+ or severe dermatosis. Now remember that dermatosis is not an indication for admission in the malnutrition ward. If the child only has dermatosis, it's not an indication for admission. Now the 5 things that can cause complications in the first 24 hours of the child include hypoglycemia, hypothermia, dehydration, electrolyte imbalance, and infections. And we want to actually address these things when we're stabilizing the child. Moving to station 2. A child comes in with a 3 days history of diarrhea, or comes in with 3 days of diarrhea. Take a relevant history. So these history questions are always just the same. Whether you're in pediatrics, whether you're in surgery, whether you're in obs and gyn, think of it as if you are actually dealing with the patient. So remember, when you're dealing with the patient, how are you going to approach this? And how are you going to take the schematic? You're on a cold day, it's very busy, and you're receiving a lot of patients. So here comes the answer. So if it's, of course, a physical OSCE stations, greet the patient and the guardian, introduce yourself and gain consent, ask for the name of the child. The name of the guardian, the name of the child. Ask them, is this the first episode of the diarrhea? When was the last time the child opened bowels? Has the child fed? When was the last meal? And how many feeds per day? What's the frequency, the consistency of the diarrhea? Is there any blood in the stool? Is there any alternating patterns of diarrhea and constipation? Any constitutional symptoms of fever, night sweats, weight loss, anorexia? Is the child breastfeeding? If so, are they exclusively breastfeeding or they are mixed feeding? If they take formula, how is the formula made? And what's the immunization history? Have they received rota vaccine? And the past medical history. What's the HIV status of this child? What's even the HIV status of the mother and the father? What's the source of their water? And of course, if it's a physical OSCE station, do not forget to thank the patient and the guardian. Station 3. Study the picture shown. What is shown in the picture? Outline the Zambian expanded program on immunization. That's what EP extended. I don't know if this is extended or expanded. I think it should be extended. One of the two, but it's to do with immunization. So you may pause the video. I know you have watched the video on immunization. If you haven't, then check out the playlist. Then here comes the answer. So this is a child receiving an oral vaccination, and the outline is as follows. So the first vaccine that we give is BCG, which is pretty much TB. We give this at birth or within the first 2 weeks. This is supposed to be 2, not 12 weeks. Okay? Then, or rather, it should be 12 weeks. Anyways, I'll confirm that after the video. But we do repeat if the scar hasn't necessarily formed or if there was no reaction, but there has been some changes to this. Then the other vaccine that we give in the first 14 days or the first 2 weeks is OPV0. Then we give the vaccines now starting at 6 weeks. So at 6 weeks, we're going to be giving oral polio vaccine, diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenza type B. We give the first dose at 6 weeks, the second dose at 10 weeks, that's 4 weeks after, the third dose at 14 weeks, that's going to be at 4 weeks after the second dose. And remember that now we're also giving IPV, so we also give IPV only a single dose together with OPV0. If the patient actually didn't receive OPV0, then you have to give them OPV4 at 9 months. Then, of course, the next set of vaccines is going to be started off at 9 months. So we're going to give our measles and rubella at 9 months, and then measles and rubella at 18 months as well. Remember that we also give PCV1, PCV2, PCV3 at 6 weeks, 10 weeks, and 14 weeks respectively, and then Rota is only given twice at 6 weeks and 10 weeks. I went into a lot of details about this on my video on immunization. Station 4. A child presents with bluish discoloration of the tongue. A chest x-ray is done and is shown in the picture. What does the x-ray show? And explain the anatomical basis. What is the diagnosis? Name 4 other cardiac conditions that may present with cyanosis. I know you're thinking, these questions seem new. Of course they are new. These are not going to be seen in the ultimate bazooka, so please pay close attention to some of these stations because you may not have come across these things even when you're studying. So here comes the answer. So obviously this here is what is referred to as a snowman sign. As you can see, this looks like a snowman. I'll show you a picture in the next slide. Or you can call it as a figure 8. It looks like a figure 8. So the head of the snowman, which is of course this aspect here, is pretty much going to be made up of the superior mediastinal shadow that's going to be formed by the superior vena cava on the right, the vertical vein on the left side, and the left brachial cephalic vein superiorly. That's what's going to be making the head of the snowman. Then of course the body of the snowman is going to be the heart. This is seen in a condition that's known as total anomalous pulmonary venous return, and the other cyanotic conditions, remember all of them start with a T: tetralogy of Fallot, tricuspid atresia, transposition of the great arteries, truncus arteriosus. Here's the snowman. So this is the head, and of course this is the rest of the body. Moving on to station 5. A 6-year-old child presents with difficulty in breathing. A diagnosis of mild viral infection is made, and a chest x-ray is taken and is shown. What is shown by the chest x-ray? What is the diagnosis? How would you manage this child? So you may pause the video, have a look at this x-ray. Don't worry about this. This is probably the mother who's holding on to the child, because this child may have actually been fidgeting around, or rather they wanted to position the child correctly. So here comes the answer. So on the right side of the lung, this is supposed to be right, not left. This should be right. This should be right. Let me just correct this right here, right now. This should be right, okay? So that I don't say that, no, he's misleading us. You see that we all make mistakes. So let me just correct this. Must have been a typo. So this is absent lung markings on the right hemithorax. As you can see, we can't see any lung markings here. We can also see that there is now the shift of the mediastinum. I've corrected both of them and I've corrected this here. So there's a shift of the mediastinal structures towards the right over there. Or the left, not the right, the left. I don't know what's happening. I'm becoming... switching my sides. So this is most likely a pneumothorax. It could be secondary to the same viral infection that this child had. So what we're going to be simply doing is admit the patient, give them oxygen. You may perform needle thoracostomy, where you go into the second intercostal space with your cannula to relieve the pain as you await an intercostal chest drainage, which is going to be your definitive management. We want to treat the underlying infection if there is an infection that is there in this child. Station 6. A 6-year-old child presents to the emergency department with difficulty breathing and an x-ray that is taken. What does the x-ray show? List 4 causes. So you may pause the video and here comes the answer. So, I don't know. I think I added another question here. What is the diagnosis? This must have been a question. What is the diagnosis? List the causes. Yeah, I should have added a second question. Here comes the answer. So here you have a left-sided homogeneous opacity. You can't see the costophrenic angle on the left side. So this is obviously consistent with a left-sided pleural effusion. Things that may cause a pleural effusion in children include infections like pneumonia and TB, trauma, which could be attributed to a hemothorax. It sometimes could be a chylothorax. It sometimes could be a malignancy, although those are not so common in children. That's why I put that as the last option. Moving on to station 7, which I am sure you have never seen. Some of you probably may have. And anyways, a woman expecting a child goes for ultrasound and the following image is shown. The woman comes to the pediatric department, or pediatric is supposed to be department, not patient, to ask for advice. What is the diagnosis? What are the complications this child will likely face? So you may actually pause the video. And here comes the answer. So this obviously is your gastroschisis here. So there's protrusion of the bowel content. It's different from what an omphalocele would look like. I'll show you what an omphalocele looks like on an ultrasound, but this is most likely gastroschisis. You can see the intestinal contents like that outside and exposed. So this child, long-term, may have prolonged ileus, they may have wound infections, they may have sepsis, they may have associated intestinal atresia, they may have intestinal stenosis, they may have malabsorption, they may even have necrotizing enterocolitis. So when the child is having an omphalocele, this is what the omphalocele looks like. So it looks like it's like the child has 2 heads over here. So this is a healing omphalocele in a baby. Then this is what gastroschisis actually looks like when the child is born. So as you can see, the intestines and all the contents are not really covered by a membrane. Moving on to station 8. A 13-year-old female is brought unconscious and hyperventilating. What important questions would you ask on your history? What are the possible causes? List 4 investigations you would order. You may pause the video right now, and here comes the answer. So you pretty much want to ask about the child's health and the activity in the last 24 hours. Is there any history of a similar illness? Did they have any previous pre-existing neurological disability? Is there any history of weight loss, weakness, fatigue, excessive urination, excessive hunger, and eating habits that have changed? Is there any recurrent oral thrush or vaginal thrush, abdominal pains, vomiting, fever? All these things are pointing towards diabetes as well as infections. Is there any personal or family history of diabetes and asthma? Have they taken any drugs? It could be like a toxin. Have they ingested any poisons or any noxious substances, any open containers that you may have noticed near this patient? Then, of course, what was their last meal? Do they drink alcohol or any substance abuse? Is there any history of a trauma in this patient? So 4 possible causes that can cause unconsciousness and hyperventilation. It could be diabetic ketoacidosis, hypoglycemia, asthma, salicylate poisoning, organophosphate poisoning, and sometimes paracetamol poisoning. So 4 investigations would want to do a serum ketones to rule out, of course, your diabetes, but you could also do your glucose estimations, your full blood count with a differential count, urea, electrolytes, and creatinine, to check how well the kidneys are functioning, a rapid diagnostic test, and a malaria parasite slide to rule out malaria. arterial blood gases, liver function tests, as well as urine electrolytes and urinalysis that may rule out your diabetic ketoacidosis. Station 9. A child presents with a history of fever and excessive crying. What questions would you ask the mother to help you make a diagnosis? Lumbar puncture reveals bacterial meningitis. What are the most likely causes? So you may pause the video right now, and here comes the answer. So you want to ask if there is a history of poor feeding. You'd want to ask if there is a history of convulsions or twitching. Most likely in the children, they're very, very subtle, especially in the neonates. They're very subtle. It could be lip smirking, bicycling. It could be boxing. Is there any abdominal distension? Is there any yellowing of the skin or the eyes? Is there any vomiting or diarrhea? Is there any difficulty in breathing? Is there any reduced activity? Is there any increase or decrease in the tone? Now, that we find out that it's meningitis, the causes in children are as follows: Escherichia coli, Listeria monocytogenes, Group B Streptococcus, Streptococcus pneumoniae, Haemophilus influenza, as well as some cases Staphylococcus aureus. Station 10, which is indeed the final station. A child presents to the emergency department with diarrhea and the following sachet is given to the mother. So here's the sachet. Describe what it is. How is it given to the patient? What alternative can be used if this child presented to AO7? AO7, by the way, is the malnutrition ward. What are the dangers of giving the standard preparation to a child in AO7? What clinical features will indicate that the patient is not improving despite the caregiver claiming that the child has been taking it well? What is the electrolyte composition of oral rehydration solution in millimoles per liter? So you may pause the video, and here comes the answer. So this is, of course, a low osmolarity oral rehydration salt sachet. And how we prepare this, we usually take one sachet, we put it in 1 liter of clean water. And then, of course, this is given by a spoon or in a cup as small sips. Then this, for those that have malnutrition, we usually often give them rehydration salts for the malnourished child, which is Rizomol. That's if they're not in shock. The reason why we give this is because if we give the standard preparation of ORS, it has a high concentration of sodium, so it may lead to hypernatremia. And how do we know that the child is not improving despite their hydration? They'll still have features of dehydration. The sunken eyes, the loss of skin turgor, the inability to drink, lethargy, floppiness, dry mucous membranes. When they cry, they won't have any tears. Not being able to pass urine. The anterior fontanelle may be sunken. If it is still open, there may be a decreased level of consciousness, poor perfusion, a fast and faint pulse, as well as rapid breathing. Then, of course, in the oral rehydration salts, sodium is about 90, bicarbonate is 30, potassium is 20, chloride is 80, glucose is 110, and citrate is 10. And here's our question for the day. A 4-day-old child presents to the emergency department with complaints of not passing stool. An abdominal x-ray is taken and the image is shown on the right. So this is the image here on the right. What is shown in the x-ray? What is the diagnosis? List 3 things that may lead to failure to pass meconium. So comment on the section below. I will pin the answer that has the most relevance to the question on the video. Thank you for spending your time to listen to this video. If you enjoyed, consider subscribing, hit the bell notification icon to show some support, drop a comment, drop a like to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.